Good morning, everybody. Good morning. We're going to start, and I left the door open for this occasion so that some of the last people who got drenched in this pouring rain can still come in. Everybody who's here get extra brownie points for their resilience and being waterproof. So that's a very special occasion. And for me, it's especially exciting because this is the first time I get to chair this fantastic opportunity to introduce our distinguished speaker, Dr. Raul Nogueira, who is our 10th Similar Fisher visiting professor. And in the best of the neurology traditions, I'm not going to be reading all the titles and all the biographies because you can do that in the little booklet. I'll tell you a couple of stories. And you know, those stories are going to be short, I promise you, because I only have 5 minutes and we really do want to hear Raul speak. But for those of us who knew Dr. Fisher, like Merritt, like Steve, like Andy, and many others, and Raul, who worked with him and trained closely with him, they were very fortunate to learn from CMF, who was the master of the method, of course, himself, the maestro of clinical pathological correlation, the self-proclaimed noticer, who said in his memoirs over and over again that all he had to do is to show up to work. And these amazing, wondrous neurological observations just showed up fresh to his curious eye. And that comes, of course, from someone who described an unbelievable breadth of neurological syndromes and studied in depth microscopic origins of disease, setting the whole new era of diagnostic and interventional cerebrovascular neurology. But for someone like me, I was fortunate because as a medical student at Boston University, my mentors, Drs. Carlos Case and Phil Wolf, they were unequivocal when I sought their advice with regard to the residency program. They said, Natalia, if you're serious about stroke, you go to MGH. And I just followed their advice, but they were deeply influenced by Dr. Fisher's training in their early years. And, you know, I had not been half aware of the world of opportunities that will open up for a wide-eyed stroke enthusiast and a budding stroke researcher. I arrived to MGH neurology the same year Dr. Fisher stopped coming in because he took care of his ailing wife. But I felt that he's been here for the past 22 years in the hallways, days and nights that we spent here, just because of the spirit of his legacy and his methodologies that we adopted. His method resonated and continues to resonate in everything we do in stroke, but most importantly, in the most thoughtful approach that we take to every single patient's care plan, thinking through the individual underlying mechanisms of disease and how we can apply the existing knowledge to each individual patient's case to guide their treatment and intervention. And in that way, he truly is, in my mind, Dr. Fisher has been the first really stroke neurologist and perhaps one of the first neurologists that brought this concept of personalized medicine that we continue to chase, and it's really a unicorn. And in that, he's been a transformative figure. Speaking of the transformative figures, Raul Nogueira. My first memory of Raul was as if NM1 in the early 2000s, in the middle of the noon conference, where we were all bamboozled by an especially mysterious case that we were presented. And this random guy in scrubs, because in those days Raul was going through his neurointerventional training, would sneak into the conference room, grab a sandwich, and will try to get out. And on the way out of the room, he would say something random like, could this be a Susac syndrome? And we would all be scratching our heads trying to learn what does it mean and, you know, kind of learn from his example. Then Raul became a neuro-ICU attending when I was a fellow. And later we worked together on the interventional cases in acute stroke. And I tell you, in mid-2000s, it wasn't a walk in the park. And I believe my personal record together was spending almost 6 hours in the Embo suite on grade 2, Raul. I will never forget those hours, where Raul was methodically trying over and over and over again to break up the clots, one device after another. And so, you know, Raul, in those early days, I called you a pit bull. But I know that it's this determination, your passion to do the right thing for every patient who could possibly benefit from your skill, your quest for evidence, your integrity, your unbelievably hard and long work hours. It's what made you the trailblazer, the innovator, the compassionate physician that we know, the intellectual master, and the technical virtuoso that you have become as you flew the MGH's nest. And I hope you know that you've changed the world of stroke care forever and for the better. And we are so proud to know you and to call you a member of our extended MGH family. And that's why you are a perfect choice for this honor today in Dr. Fisher's name. And I'm sure Dr. Fisher would be very proud. Please come and collect your CMF.
Wow. Well, it's a real pleasure to be back here. I can't, it's hard to put in words what an honor and privilege to be here to celebrate one of the whole models I have had in my life. I feel extremely fortunate to have met Dr. Fisher. I think undoubtedly one of the most influential neurologists of the modern times. But not only an influential neurologist, I got to know him. You know, if you want to know who someone really is, you ask the people who are under them who they really are. And the words that would come out, at least from me, and I believe from everyone who are trainees, students, is kind soul, nurturing mentor, patience, resilience, faith. So this is a tremendous honor, I think, to be here to celebrate his life and his work is probably one of the biggest gifts I could have in my professional life. So thank you very much for this. So today we're gonna be talking about some of my work, and I would like to say this is and always will be my academic home. So this is how I feel, right? The only difference, the fundamental difference is I'm not here to ask for forgiveness for having wasted your fortune. I'm here to say thank you, my deepest gratitude for having shifted my life. I came here as a clinician. I'm sure I would have gone back home and being in Brazil, having a happy but ordinary life. I left here as a clinician scientist, as a research, and because of that, because of this shift in my life from this place, I believe I have lived an extraordinary life. And with that in mind, you're going to be discussing the journey of endovascular therapy. We're going to talk about the mistakes from the past, what is happening now, and hopefully what's coming from the future. But I have to mix that with my own personal and academic journey. And again, this is a history of gratitude. Here are my disclosures. I do a lot of clinical trials. I do interact with industry. I would like to say that the main problem here is that I absolutely love what I do. Natalia remembers that very well. So I'm likely highly biased, and it's okay. Take what I have to say with a grain of salt, but that's fine. But here is my main disclosure. And I hope this
I'm always saying, well, look, I worked hard and I've got some talent.
So yes, I work hard.
There are a lot
of I have talent.
hard-working, talented people out there.
In order for you
there was this element of chance to it. There was this
some
element
success in life, sometimes there is this element of serendipity. And this was very well said by someone who's obviously one of the most accomplished people in the late times. And here is what serendipity is for me. This is Fortaleza, my hometown. This is Northeast Brazil. Yes, it's gorgeous. You can ask man, how come did you leave, right? But, you know, going from Fortaleza and up in Mass General, that's serendipity, okay? This is serendipity, and I will be forever grateful to the people who decide to take a risk in some unknown resident from Fortaleza, a student from Fortaleza, Brazil, and gave me this incredible opportunity that once again changed my life. And many of you participate in that process. So I'm very grateful for being able to add a drop in the ocean of knowledge when it comes to stroke. But I want to keep in mind that I only could do this because I was lucky and fortunate enough to be in a place like this. I love revisiting the past. It helps us understanding the problems that you have. And it is amazing that the inception of endovascular stroke therapy actually dates back from 1958. Sussman and Fitch put this paper together. They gave intra-arterial plasmin for patients with MCA, ICA occlusions. This actually predates coronary intervention by over 2 decades. So what did you do wrong? How come they evolved so much faster than us? And the answer is here. We commit the original sin. As you're trying to climb the tree of evidence-based medicine, went to the low-hanging fruit, the single-arm trials, as opposed to the high-hanging fruit, the randomized clinical trials. Yes, we had a couple of very small, inconclusive randomized trials, but then it was all single-arm. Then very much like politics nowadays, you had these polarized opinions like recanalizers like me versus non-recanalizers like Dr. Powers, and you're fighting this battle without any evidence. But it's important to revisit the past and then understand the repercussions that the past has had in our present and hopefully not so much in the future. This bad past that you had, the way we start wrong, it creates this confusion in our decision-making process. There is a big confusion in our field between what is a predictor of outcome versus a treatment effect modifier. And the reason for that is simple. When you do single-arm trials, that's how you build our history, right? If you compare a patient that had the treatment with another patient with different characteristics that also have the treatment, yes, you're going to define the predictors of outcome. Obviously, the older you are, things are going to be worse. The bigger the stroke is, things are going to be worse. The more delayed the treatment is, things are going to be worse. Makes sense. However, cardiologists, and we now have the benefit of randomized clinical trials, you can then compare similar patients that have treatment versus not. When you do that, you can establish what really matters for your decision making, which is what is a treatment effect modifier. And age, it's not a treatment effect modifier. Yes, the older you are, the worse is going to be your outcome in comparison to the younger with treatment. But without treatment, your outcome is much worse than the young. So the treatment effect size, if anything, it's bigger. Okay, so, and that applies to other aspects, such as aspects of size of the stroke and time as well. So predictors of outcome tells us prognostication, who does well with the treatment. However, the key question is who does better with the treatment, who benefits to some extent, and that is answered by treatment effect modifiers. And we do a lot of imaging. I'm trained here. The radiology colleagues from here were wonderful. They embraced me, they trained me. I'll be forever grateful. And I love doing research in imaging, but we have yet to identify any imaging surrogate biomarker that will nullify the benefit of thrombectomy. Also, problems in our field is we start wrong. You had trials that suffer from lack of equipoise, from poor design. You didn't have the right technology, and you had 3 negative trials in 2013. It was a very traumatic time for people like me. But sometimes a problem gives you an opportunity to rethink. And we could redesign things, but we also got more sophisticated. It became obvious that we were using dichotomized outcomes. And that's not really fair. You have 6 transitions from normal all the way to death in the modified Rank scale. It made much more sense to actually value every transition of the modified Rank scale and change the primary outcome to ordinal shift analysis. And subsequently, you actually understood that these transitions have different weights to patient and family. And I believe the utility-weighted MRS is even better, although it's been harder to adopt because it's a little more complex to understand, and the FDA doesn't like it as much. But we finally understood that sometimes it's not possible to have the home run, right? The patient's too far gone, there is too much damage. It's a situation that is just not favorable enough, but you still can have a better outcome. So sometimes a good outcome is not possible, but you shouldn't give up if you can still bring a benefit. And this has been a unique problem in stroke. We're gonna revisit there towards the end. The other thing that really helped us is that devices, they evolve. We start with the Mercy, and yes, we had hours in the industry, Natalia and I, with that technology. Things were getting better with aspiration catheters, start deploying stents, and then game changer, stent reversers. We are now in the megabore catheter psych aspiration area. And while I really don't know what's coming up, I know you're gonna have a lot of work to do because our habits are just off, right? So these second generation devices were really game changers, and we had the honor of participating and leading some of these trials where you demonstrate this new stent retriever technology was much, much superior than the coil retrievers, the Mercy device. And this really helped moving things forward along with better design trials, better patient selection. We then had the global victory. This is like 2014, 2015. You had 5, soon afterwards 6 randomized clinical trials that really showed an overwhelming benefit of thrombectomy. You can see here the shift towards better outcomes. In some, you are 2.5 times more likely to have any improvement along the MRS scale at 90 days if you have thrombectomy than not. You are also 2.7 times more likely to achieve functional independence at 90 days if you have the treatment than not. So what a home run. But people like me had the benefit of kind of coming from a different world and understanding the world is not homogeneous. This is the reality in the public healthcare system of my country. Very different reality, very different infrastructure. So some of us didn't consider that such a global victory. The first world is not enough. And then we decide to do a trial that would give data to the 80% of the world that lives outside the reality of first world countries. And there were reasons to do this. In a country like Brazil, you have 2 realities. There is the reality of people like me and Barbara, right, that were privileged to live in places like this. And then there is reality of 80% of Brazil that actually depends on the public healthcare system, including people who live in favelas and rural areas. And that's a very different population. There are a lot of unique aspects, but specifically this vulnerability of this population. The pre-treatment network is not as mature. We lack infrastructure, you lack technology, you lack training. There was zero access to rehab. So when the trials were positive, you went to the Brazilian government and you said, you should pay for this. This is great. And they go like, I don't think this would work in our reality. It took 17 years for them to pay for TPA. We didn't want that to happen. So you said, can you sponsor a study? And let's see if you can make this work. And this was one of the great experiences that you have. Again, I think we have this very unique setting where you could study this population that is much more vulnerable to their poor socioeconomic status, higher rates of comorbidity, lower nutrition, bringing higher frailty. And we know that as you go down in terms of your socioeconomic status, you can see here in this paper, the case fatality in stroke actually increases. Okay, so it's a different reality. You need to validate the treatment in this different reality. Remember this. And with that, you put a network of academicians together in Brazil, kind of sold this dream to our colleagues. We spend a lot of time training them in how to do thrombectomy. And we even went there, and in the trial, we did a few of these thrombectomies in São Paulo, in Fortaleza, my hometown. But the heroes really are all these people that essentially work for free. We didn't have money to pay for the study. We could barely pay for the CRO. We got donation of the devices, and you got this done. And luckily, we showed a very high benefit in this paper in 2020, where we showed a 2.3 times higher likelihood of any benefit, even in our less privileged reality. And you can see here that patients were 2.6 times more likely to achieve functional independence at 90 days. So we validate the treatment in this very different setting, which is important because it reflects what happens in most of the world. No safety concerns, no increased death, no increasing rates of hemorrhage. However, remember what I told you about case fatality. You can see here, as you compare with the first world countries, the mortality of both treatment and control was 1.5 to 2.5 times higher. So you were not wrong. It is indeed a different setting. The rates of bad outcome, MRS 5 or 6, also a lot higher than any of the other countries, but it's actually one of the only studies that could show a statistically significant difference in terms of decreasing bad outcomes. So yes, our people, they have worse prognosis, but they have a maintained treatment effect, preventing bad outcomes and also achieving good outcomes, as you can see here. We then demonstrate the cost-effective analysis of this. We published this in Journal of Stroke, and that's when even a small drop can have a ripple effect. I think the government at that point had the evidence that they need to incorporate the treatment, and with that, I think I could give back some of what I took from my country, and it was really a special moment in my life. We then saw a lot of influences, specifically in Latin America. Chile and Uruguay soon started to have policy changes when it came to thrombectomy. In parallel to that, we were doing also work to expand the treatment window. This was something that became very clear to me during my time here, working for colleagues from neuroradiology, working the ICU and the stroke team. For the residents, clinical research is a lot about pattern recognition. So being in an intellectually stimulating environment, seeing a case after another case, as Dr. Fisher said, try to find patterns. And it became clear that, yes, time is brain, but there are other variables. And collateral flow buys time. And here is what collateral flow is. You have a blockage. How come you are feeling the digital brain? Well, you can go around through these little leptomeningeal collateral changes and feel this. And if you're feeling it completely and very quickly, your NIH stroke scale, your clinical severity is going to be low. If you're feeling borderline, it may be high, but you are buying time. You are kind of slowing down the stroke progression. If you haven't any of this, you are a fast progressor. So we could try to redefine this concept of time, of this therapeutic window, using this interaction of collateral and time. And again, you learn by seeing and doing cases. Here is a 74-year-old, very high NIH stroke scales, less than 2 hours, but no collaterals. And you can see that this patient very rapidly on MRI had a fully developed stroke. What do you learn here? Less than 2 hours, early time, but poor collaterals, poor outcome. This is what you define as a fast progression. On the other hand, similar demographics and baseline characteristics, approximately 16 hours from time less seen well, but collateral flow. Look at the imaging pattern. This is after we did a thrombectomy, right? So what you learn here, late time, but good collaterals, you can achieve a good outcome with reperfusion. This is what a slow progression is. So you have to stop thinking about population. This is how stroke grows over time in a population. But yes, you do analysis in population, but you treat one patient at a time. You have to understand whether that's a fast or slow progression and adjust your treatment paradigm as such, because there are many other things that will contribute to stroke progression. With that in mind, you put together a multi-centric analysis to kind of validate this paradigm in a retrospective manner. And we could conclude that with this, you had a good chance to then do prospective randomized clinical trial that we published in 2018 called DAWN. Our colleagues from Diffuse 3, soon after our trial, I believe they stopped the trial because our trial was positive and their trial was also positive. We then have about 6 trials that enroll patients after 6 hours, DAWN being the only one all the way to 24 hours at that point in time, but you can put them together in what you call the Aurora meta-analysis. And here is the summary. Same shift we saw in the early window, same number. You are 2.5 times more likely to have any less degree of disability. But you are actually almost 4 times more likely, 3 times more likely to achieve function independence at 90 days. And as we saw before, our subgroup of patients benefit from treatment. And that's the story of the early analysis of the late window. But then we start to think, we over-select these patients. We want to make sure that you had a positive trial. So you really got the patients that had the highest chance. You are still leaving many people behind. There is a problem of over-selection. This is actually very clear if you look at the early window trials here. As you go, this is the order of doing more and more imaging across these trials, okay? Non-contrast CT, then here you have aspects, CTA collateral, CT perfusion. As you do more image, look at what happens. Your outcomes get better in the treated patients, but your outcomes also get better in the control patients. So you are excluding patients from the control. That could potentially benefit to the point that if you compare thrombectomy, Mr. Clean, with controls and extend IA, the controls are actually bad, right? So it shows you that image is filtering out too many patients. Let me try to explain this phenomenon of over-selection a little better. Here you have 2 hospitals. The first hospital chooses a more sophisticated paradigm of, let's say, CT perfusion. Have here 100 patients. They select these patients. The number need to treat here is 3. 70% will have good outcomes. This is absolutely amazing. This is the reality of the Extend IA trial in Australia. A very large treatment effect size. This other hospital is more like the Mr. Clean trial, more like a pragmatic approach, less selection. Same 100 patients, they treat more people, they don't do as well. The number need to treat almost doubles, they have half of the rates of good outcome. If you are a patient, where do you want to go? Do you want to have twice as much higher chance of having a good outcome? Or do you want to have a higher chance of getting treated? Well, if you look, and this is what you call the denominator fallacy, okay? We are not only responsible for the outcomes of the patients we treat, you are responsible for the outcomes of our patients we had the opportunity to treat. That's our duty. When you look at the whole 100 patients here, right? What becomes clear is that you end up treating 10 out of 100 patients. Here, sorry, you end up benefiting 10 out of 100 patients, right? You treat 30, number needs to treat is 3, 10 benefit. But here, even though the treatment had a lower treatment effect size, you treat more patients, you end up actually benefiting 16 patients. 60% more people benefit. And the problem is there is a lot of pride in what you do. You always want to have the home run and the good outcome, but you can't do that at the cost of leaving patients behind. So the question became, do you really need all this image in the late window? And we start doing registry work where you demonstrate that outcomes in CT, CTA were just as good as CTP in the late window. This is another collaboration between me and our esteemed colleague Dan Ewan that showed the same thing, CT, CTP, MRI selection in the late window led to very similar outcomes. We then had the Dutch doing the Mr. Clean Late, just using CTA collaterals as the criterion. That was a positive study, as you can see here, with a common odds ratio of 1.7. So you broke this paradigm of advanced imaging even in the late window. We then did a trial in Brazil, the second resilient trial called Resilient Extend. We present this recently. We have to understand that public healthcare system setting, but the idea here was to melt the clock of time, right? We just want to show that we can go all day to 24 hours using simple paradigms that can be used everywhere in the world. Very typical design, 90-day outcomes. But again, we're using non-contrast and CTA paradigms versus advanced imaging. And we randomized 256 patients, 126 thrombectomy and 119 control. We finished the trial early due to several things, including the fact that Brazil approved the treatment. At the moment they approved the treatment, that would be no longer equipoise, so we finished. And you can see here the primary outcome when you look at the chances of 0 higher, 0 to 1 higher, 0 to 2 higher, 0 to 3 higher, then oops, 0 to 4, not higher, actually lower, and 0 to 5 also. So this creates a problem to analyze the common odds ratio, because the common odds ratio is an odds ratio that should reflect all transitions. So what you have here, if you try to calculate it, will be negative, but it can't be done because the proportional odds assumption was violated, okay? And then when you have that, well, you have to just interpret the result in a different manner. You went to our secondary clinical outcome, and you can see here 27 versus 15% of the patients achieve MRS 0 to 2 at 90 days. And this gives us an adjusted odds ratio, again, around that 2.5 you always see, in this case, 2.7, statistically significant with a number need to treat of 8, doing late treatment 8 to 24 hours without any advanced imaging. And here are the different transitions. You can see, again, there is kind of a bidirectional effect here. What you can conclude is you are statistically, you have statistically higher chances of having excellent outcomes, 0-1, good outcomes, 0-2, but there may be, right, this is not significant, but there may be a price you pay in terms of potentially also having worse outcomes. This has happened before. In fact, this has happened, this proportional odds ratio assumption violation, even in the biggest trial of stroke trial at all times, right, was the NIN, the STPA trial. So it's been seen before. Safety was great, no problems with symptomatic intracranial hemorrhage. But then we found something that I think it's very, very important, which is the analysis of age. And what you call old in Brazil, it's a little different, specifically in the public healthcare system. We had 174 people that were younger than 70 and 71 that were 70 or older. No differences in baseline characteristics other than the age, of course. And then when you look at the outcomes stratified by age, the people, should say 70, I'm sorry, the people who were younger than 70 had the highest odds ratio that you have seen across any subgroup analysis today. Okay, very, very high treatment effect. However, the people that were older than 70, they didn't benefit. They were actually perhaps harmed by the trial. And here is, again, looking at the interaction of age, and you can see there is statistically significant interaction with a very robust treatment effect in the young, but potentially harm in the elderly. It's the first time you will see that in any cohort of patients. You see the same thing with 0 to 1, but this is likely not related to differences in mortality or symptomatic intracranial hemorrhage. What does it, right? And now I think we're trying to drive this, at least for the young patients, anywhere in the world. You don't need advanced imaging. I think the Mr. Clean Late also helps with that. So hopefully this is gonna change guidelines. And we'll talk a little bit more about why we think that's the case. But we're gonna shift gears a little bit to talk about one of my big passions, which was the basilar artery occlusion. Was very, very hard to prove this treatment. We collaborate with colleagues in China to do large registries where you saw in close to over 2,000 patients in the attention registry, also in the Basilar registry, that yes, this seems to work. Thrombectomy for basilar artery occlusion works, but everyone wants a randomized clinical trial. And we did do one in China, and we published in Lancet Neurology. There was loss of equipoise, a lot of crossover, so you had a near miss. The Dutch, actually, with the help of my colleagues in Brazil, also had a near miss. Not positive, but the subgroup NIH greater than 10 was positive. But because these two trials were not positive, my colleagues from China approached me again and said, do you think you can do another trial? And I say, yes, as long as you promise no crossovers. And then we did the attention trial, and that was highly positive. In parallel, the BioCH trial was done in the late winter. So this was 0 to 12 hours. This was 6 to 24 hours. And here are the results. You can see that patients with thrombectomy had 45% MRS 0 to 3. Essentially, they can walk on their own versus less than 30%. This was highly statistically significant with an odds ratio around 2.5. So that number 2.5 keeps repeating itself. And when you look at all the secondary endpoints in terms of the shift at 2.5, in terms of in terms of 0 to 2.5, in terms of shift 2.1, you pay a price. You do have more hemorrhages, very much like intravenous thrombolysis, but despite more hemorrhages, you actually decrease mortality. Okay. So a great treatment. Also, we just published in this meta-analysis, hopefully soon, you help cardioembolic strokes, you help strokes from intracranial atherosclerotic disease. These are separate analyses showing statistically significant benefit. You help people who receive and don't receive intravenous thrombolysis, but there is a group of interest. Those with NIH stroke scale less than 10 may not benefit from thrombectomy. Okay, but then you need to break down, is it a 10 with high disability, a 10 without high disability? We don't know yet. I think this is a population that needs to be studied further. But this is really something that's very dear to my heart. I think Natalia mentioned something called resilience. And out of the blue, after Natalia was kind enough to come, invite me to come back here and talk to you about this work, I got this beautiful thank you note from a patient that I had treated 18 years before. He had a basilar artery occlusion, and he essentially says now he's a full function 72-year-old man who has been able to walk his two daughters down to the aisle, very much like I have my two beautiful daughters here. I would like to have that privilege, and I feel extremely fortunate to have helped someone achieve that with the help and faith of people like you. Right? You always believe that you should try to do this. You had that give the benefit of the doubt to these patients. He now has grandsons. And he actually says here, thank you again. He says something about the fact that, yes, that a general block my brainstem. Thank you for trying different ways to unblock it. This essentially tell me that I was there for a while and he knows about it, right? He also mentions the giddy smile that I had in my face. That's very typical. This is another case that I share with my colleagues here at MGH. I just talked to Patricia Mussolini, who said she still follows this young boy. He came here. They were thinking that he had convulsion seizures. He was actually having spontaneous posturing from a basilar artery occlusion. Here is the Mercy device, worked pretty well. But here is the thing. I remember Anish Singhal called me. This was Mother's Day. I was driving my family to have lunch. And then he said, how the MRI looks really horrible, but you know, I don't know. And I go like, man, it's Mother's Day. We gotta do this, even if it's for his mother's sake. And who knows? We think this is dead brain. But if you don't open the vessel, you'll never know if it can be reversed. So let's do it. And here is what happened. Here is before, here is after. And you see, it is not full, but there is a fair amount of DWI reversibility, okay? And this is a great quote, okay? you gotta, if you wanna do research, break dogmas, okay? Don't believe in everything, question things, okay? And we now know that the WI, yes, it's very good, it's reliable, but it can be reversed, right? And the other thing I would point out is I have had cases of this where you try to refute the self-fulfilling prophecy, you gave the benefit of the doubt. And these patients with extensive brainstem, this is post-treatment MRI, bilateral brainstem involvement, not even a pronator drift. I have at least 3 or 4 of these patients now. And some of my colleagues have. I have patients that were locking for a couple of weeks. I talked to the family about comfort measures only. They said no. And this guy walked to my clinics 90 days later. So I think you have to be humble. There is a lot that you don't know, and give patients benefit of the doubt. I want to acknowledge the collaboration of my colleagues from China in these different networks here. It's been a pleasure to work with them. For the last moments, I want to just talk about some of the new frontiers. There is what you know, you just discussed. There is what you don't know yet, specifically LVO, large vessel occlusion with low NIH 0 to 5, you don't know what to do. The digital occlusions, you don't know what to do. We're going to talk about the fact that we do know what to do for large strokes, and we now know what to do for late presenting strokes, even in the setting of advanced imaging. We talk about restricting late and extend. And starting with the mild strokes, very common problem. 60% of all strokes have NIH 0 to 5. 40% of our intravenous thrombolysis, NIH 0 to 5. Whether or not you should be doing it, I don't know, but that's what happens. And even 11% of the EVTs. Many of these patients, 1 in 2 in 10, will have a large vessel occlusion. And the problem is, if you have a large vessel occlusion and you present with a low NIH, you are relying on collaterals, and they are great, but they are unstable. So you have 10 times higher likelihood of clinical deterioration. So what should you do with these patients? Because it is a race, right? It's a race between collateral failure and reperfusion. So if you win the race with reperfusion, you're gonna have a good outcome, right? But if collateral failure beats you, or if you have a complication with reperfusion, you're gonna have a bad outcome. We don't know what to do. I specifically have done a lot of work with my colleagues to try to show that maybe you should treat these patients up front. I'm no longer sure. Many colleagues dispute that. There are reasons. So what you need to do, randomized clinical trials. We are doing a trial in the United States. There is another trial happening in France. So hopefully you're gonna know what to do with this population soon. For now, what to do? Well, avoid the patients with higher procedure risks, hypertortuosity, intracranial atrophy, calcific clots, and maybe give these patients the benefit of the doubt. If your NIH is a 3 now, but was a 15 just an hour ago, maybe your collaterals are unstable. The more proximal occlusions, they deteriorate more. Patients that are autohypertensive, you're doing great now with a blood pressure of 200, what's going to happen when it goes to 143 in the morning, right? The clinical stress test, sit the patient up or even walk the patient. If they deteriorate, maybe you want to treat those. And CT perfusion may give us some signals about what are the collaterals that are stressed. Another area of interest, I would say these are not the low-hanging fruits anymore, is the distal occlusion. Okay, should you be treating them? They are common, 25 to 40% of our cases. Intravenous thrombolysis work for them. In fact, I'm doing a trial now in Brazil called Resilient Extend IV to expand intravenous thrombolysis for these distal occlusions in the 4.5 to 24 hours window, but it's not really a panacea. It still fails to recanalize 1 in 2 patients, right? Despite the small clot burden, still fails to recanalize, and 1 in 3 to 1 in 4 don't achieve function independence at 90 days. We do have technology, small retrievers, small aspiration catheters, lytics. So should you be doing this? Well, I've been doing it in selective cases, like a patient like this that comes with a low NIH from monoplegia in the leg, essentially, right? NIH of 5, but 4 points because he can't walk with his leg, right? So if he can't walk at 90 days, his MRS is gonna be 4. Right? So even though it's a low NIH, even though it's a digital occlusion, it's a highly disabling deficit. So I believe we do have the technology. If you are thoughtful and careful, you can do these cases with a good safety profile, and you'll be treating these patients with pretty decent outcomes. And the basis for this, and you have to disclose to the patients, you are navigating uncharted territories. You don't have the proof. We can watch you can do the statement, right? But the premise here is that the patients don't care about where their occlusion is. They don't even know what NIH is. The only thing they care about is the deficits that they have to live and cope for the rest of their lives. So I think this is a patient-centric approach. Having said that, there are dangers. And I think a lot of this is defined by the anatomy, the tortuosity of the vessels, the superior division and MCA territory. This is a case, I have had my nightmares, not this one, because I really try to respect this area. These vessels, they are very, very tortuous, like a roller coaster. So put a mechanical device there that's, I think, too much. Maybe lytics would be better. But what to do with these patients now? Well, let's try to randomize, but if you can't understand the risks, and tortuosity is by far the main problem, followed by vessel caliber, and I don't care about distance. The ACA, the angular branch, you can go very distant. They are straight vessels. And obviously you need to have viable and eloquent tissue to justify the risks. We've done a lot of work to validate the safety of this procedure. Recently, you published, just I think last week, this case control analysis demonstrate no benefit against medical treatment. However, there are groups that may benefit. The higher NIH, the patients that didn't have thrombolytics, I bet the ones that failed thrombolytics as well, right? The ones that are treated early and maybe anterior more than posterior circulation. What you should do now, randomize if you can, join one of these trials, let's get the evidence. This is probably one of the most important things to talk about because there is a lot of confusion in the large infarcts, right? You tend to not want to treat these patients. First thing you need to recognize is that the measurements that you use for infarct, they are not imperfect. There are issues both quantifying the size of the infarct, but also the quality of the infarct. We need to start thinking about two dimensions when it comes to infarct aspects. It's a big problem. I don't think you should use it. Here is aspects of 5 in a very small infarct, very small volume. Okay, not much so eloquent area. This patient can actually do pretty well versus this one, 100 cc's bigger with the same number of 5. A lot more eloquent tissue is involved here. This patient, it's not going to do as well with the same aspects. So this is like comparing sometimes, you know, a penthouse in Manhattan versus a little home in a rural area of Pennsylvania and say that they should score the same 1 point, right? No real estate agent would take that as the ground truth, but that's what you're doing, stroke. Okay, so let's go away from aspect. Another reason is the eloquence, the weight of these aspects is different. Typically, superior posterior areas are more important. So not all aspects are large, not all low aspects cause disabling infarcts. We don't have very reliable imaging. I would say CT perfusion, diffusion, reperfusion, it's equal to confusion. Here is CT perfusion with a very big stroke. We reperfuse this patient, goes core, the core disappears. So never exclude a patient from treatment based on CT perfusion alone. It's a great technique. I still use it to understand the case. It's great to find distal occlusion. Use it to treat people. It's okay to use it, but don't use it to exclude people from treatment. And even diffusion, mostly these more faint areas of diffusion, you can have DWI reversibility. So be very careful excluding these patients. Okay, so some of these estimated cores are not really large cores. And I still believe loss of gray white matter differentiator is probably the most reliable biomarker, but you need to understand things are not very accurate. We have believed in large core treatment for a long time. We were the first to publish about it, but now we have 6 randomized clinical trials. And these trials unequivocally all the way to 24 hours have demonstrated there is a benefit. The prognosis is poor. These patients don't do well. They don't have a high rate of 0 to 2, but 0 to 3 may be as high as 1 in 3. But if you don't treat them, they do terrible, right? And here is essentially the numerical summary demonstrate that most of the time you have statistically significant benefit across several of these different metrics. Meta-analysis have demonstrated this very, very clearly. I'm gonna try to go to the more important areas here. 2 of these trials actually demonstrate a benefit in terms of mortality. And this is something that's very, very important. I think the worst outcome after a stroke is not even death. It's the MRS of 5. It's the bedridden patient that it's a burden to society, to his family, and has a very, very poor quality of life. Having said that, we are not God. You should not even decide that. There are many people that are walking out there and they say they want to continue to live. So you need to think about that. But it's important to understand that none of these trials increase your chances of having an MRS of 5. Invariably, they decrease your chances of having an MRS of 5. So very important to know that. So how is it possible that this causes a benefit? We know that not all the benefit of thrombectomy comes from shrinking the final infarct volume. In fact, the Hermes meta-analysis showed that only 12% of the benefit is explained by this, by decreasing the size of the infarct. So if that's not shrinking the infarct, what else could play a role? Well, the equation is a lot more complex than only size, right? The outcomes are likely influenced not only by the quantity, by the size of the infarct, but also by the location of the infarct. And this is very important, the quality of the residual brain frailty. And this is where white matter disease, I think, has an important point here. So aspects of for young men fail TPA, large stroke on CTP, right? Not part of the guidelines. But young, I think there is still a lot of eloquent brain to say we treat this patient. Here is before, after treatment. Here is the CT perfusion. It was actually right. Here is the post-treatment DWI. So most of the time, CT perfusion is right. The problem is sometimes it's wrong, and you cannot, right, not provide treatment for someone who could have benefit from it because you made the wrong diagnosis. But despite this big stroke, this patient had a good outcome at 90 days. How is that possible? Well, it's possible because despite the high, large final infarct volume, the regional eloquence here is relatively low. This is a very forgiving area, the temporal right lobe. You know, the more eloquent area here, the posterior frontal parietal lobe is completely spared. So, and the biological age was on our side. So when you balance everything, the outcomes are good, right? So don't think about one variable only. On the other hand, 91-year-old, small infarct, but central in the motor cortex, we treat, he had a bad outcome. Small infarct, high eloquence, high age, bad outcome, right? So don't forget about the importance of regional eloquence. Age, we talk about age. One of the things that was surprising to me is some of these trials, not all of them, the large core trials even demonstrate a benefit in the elderly as well. That for me was somewhat surprising, but I believe they were really good elderly people. This concept of brain frailty is very important. Similar age, very different people, very different brains. And we talk about this. The elderly actually benefits more, even though they have worse prognosis. In the ESCAPE trial, they were the only subgroup to have a benefit in terms of mortality. We talk about this. And to close here, you're going to have the brief discussion about this issue of brain frailty. So in the trials of the first world country, what you see is as you go up in age, look at what numerically happens to your odds ratio, right? It goes up. The treatment effect numerically at least goes up. We see that in the early window 0 to 12, and also in the Aurora 6 to 24 hours analysis, see less than 70, 70, 79, 80. Treatment effect is actually higher in the older than in the younger. But look at what happened in the first trial in Brazil, younger, older, different directions. And this is the more recent trial. Why? Why is that, right? And we believe this is brain frailty. We believe, and you already showed that in the first Brazilian trial, that once you correct for the amount of white matter disease and brain atrophy, the age falls out of the model. So it's brain frailty, and obviously lower socioeconomic status, you're gonna have more brain frailty. So you need to adjust your occasions. Talking about brain frailty, we need to separate out brain frailty from MRS. Do not treat numbers, okay? You can have an MRS of 2 from early dementia in a young age and be a very poor candidate. You can have an MRS of 3 from osteoarthritis or back pain, you are an amputee, orthopedic conditions. There is no brain frailty here. You're still gonna be a good candidate. So it's not about the number, it's about the meaning of the number, it's about brain frailty. Also, don't judge. Most of us would say, I'll never treat someone with an MRS of 4, right? I think most of us would say that. If this gentleman was alive, would you treat him, right? This is the anti-brain frailty person, right? So some people, right, they have a poor MRS and they yet can have very rich lives. So think about that. And to finalize, I want to finalize by giving this concept of quality of the infarct. This is, for me, one of the biggest piece of knowledge you acquire over the last couple of years. We have to understand that infarct has a size, but it also has another dimension, which is the depth, the intensity, the quality. And the reason for that is you don't treat neurons. We treat the entire neurovascular unit, the neurons, the pericytes, right? Endothelial cells, the glia, astrocytes, microglia. And there is a differentiation to the vulnerability to ischemia across these different cell lines. Neurons die a lot faster. Gray matter before oligodendrocytes and white matter, then astrocytes, microglia, endothelial. A lot of the work done by our colleagues from the CHARM tribe, actually. You can rescue with reperfusion the blood-brain barrier, even though you have a large infarct, because you are rescuing astrocytes, pericytes, endothelial cells. So you have to understand stroke is not black and white, they are shades of gray, right? You go from normal brain tissue, more selected gray neuronal loss, progressive neuronal loss with glia, vascular cell preservation, and then finally you have necrosis. And this is key to understand. And here, how do you learn this? As Dr. Fisher says, you learn stroke 1 case at a time. And here is a patient that I treat with ACA, MCA, recanalizing, and he had a very large stroke. But you can see that even 6 months later, the scaffold of the brain is present. There are islands of neurons that are preserved, white matter that is preserved. Here is a patient that I didn't treat because he came already with a black hole very late. Very different. This stroke, it's actually smaller than this stroke. Guess who did better? The patient with the larger but incomplete stroke. And we actually have proof of concept now, because this is the SELECT trial, and there is no difference in the stroke size at 24 hours, 170 versus 170, no 168, 170, no difference. This is another trial called tension. You can see here, no differences in final infarct volume. So if you're not changing the size, or you're changing the quality, right? And I think it's something you have to embrace. In extremis show that also in some ways. So to finalize, here are the 2 equations that I would use to predict outcomes. I'm not sure this even predicts treatment effect, right? But at least outcomes. This may help you, the stroke volume, the stroke size, but also the depth of the stroke. Is it a mature complete stroke versus not? The eloquence and the brain frailty, which is the brain biological age. And remember, time is brain, but so is collateral flow. With that, I'm just gonna go to the very end here. If Lee was here, he would say how many slides up from. And yes, that's just the way I go. I can't help it. I'm too excited about it. I would keep going here for another hour if I could. I just want to say that we are doing things that go beyond the acute period, and this has been a gift. Lee Hochberg was a year behind me in residency, and when you're a resident, he shows something that I had goosebumps. He showed me a monkey, okay, with a cable playing video games through digital telepathy, and I go like, Lee, you kidding me? This is science fiction. A few years later, he published the first ever human case of BCI. This is how blessed I've been. to be in this place for my early career, is to share this space with so many brilliant minds that gave me so great opportunities. And I'm so proud of now going back, having the opportunity of doing one of the first endovascular BCI, something called a stentrode, which we implant in the superior side of the sinus. And here is my second case, actually, where we did the implant. Here is a patient, not my patient, but it's a lock-in patient, who's essentially for digital telepathy, gave information to the iPhone. And here is my patient, digital telepathy video game. He's just thinking and playing video game. He was very kind. He was at CNN recently. And, you know, what a wonderful opportunity you all have given me. Thank you so much for that. And with that, I would keep going and going and trying to make more and more points. But I'll conclude by saying that individually, you are one drop. Together, you are an ocean. Thank you so much for having had the opportunity of being part of this family. And thank you to Dr. Fisher for having give us such a wonderful center, such a wonderful philosophy, so many great disciples that keep propagating his knowledge and, more important, his kindness and dedication. Thank you so much.
You're a really example of a leader, change the field, inspired, and all just to go into. I remember that you were really a pioneer.
Thank you, and thank you for continuing to take a risk in some of the unknowns. One of my mentees is coming here next year. I reached out to you and Natalia. I promise you, you're not going to regret. It's again, I can't thank all of you enough. This has been a wonderful journey, and I have so much love for this place. It means a lot to be here. It really does.
Well, I was going to say, what are you going to do the next 4 grand rounds? Fantastic. Really. I have a question. And some of the pictures will be together. Cheaper trial. Is it move from overselection to broad selection? Something that should just happen in practice learn? Is that demonstrated? What do you think about implementing that after you demonstrate proof of principle?
I think this is a key point. So the late Johnny Pryor, who trained me, once he told me, listen, before you run, you got to learn how to walk, right? And I think in clinical trials is the same thing. You have to go for the low-hanging fruit, prove the concept, then you expand in the population. Now, through the revolution we have had with statistical designs over the last decade, or a little longer now, specifically Bayesian adaptive design, population enrichment, you can take higher risks. We're starting to do that. We actually did that in that DAWN trial, just never needed because we already started to specific. We couldn't take risks. It's a more complex story. When you did DAWN, we didn't even have proof in the early window. So you really want to nail this down. But now, if you do adaptive design with population enrichment, what you can do is you have the highest likelihood, the mid, the low likelihood, and you put these things in basket, and then when you do interim analysis, if they look like they are not contributing to your endpoint, you can exclude that. You can also do things such as sample size recalculation in adaptive designs, which will help you, because a lot of these sample size calculations, right, it's based on poor retrospective data, you don't really know. So you start, then you can recalculate. This endoload trial that you're doing now has that. Many of the trials I'm currently doing has that. But what I would say is, if you want to do clinical research, you know that funding is challenging. You know that you gotta win early in your career. So go for the long-hanging fruit. Get the first win, and then after you get the low-hanging fruit, you can climb the tree and try to get the harder ones, right? But specifically, and obviously I have one slide about that that I couldn't show because I always have too many, is the next trials, because you are almost done with the thrombectomy versus control. The next wave of trials are going to be thrombectomy plus something versus thrombectomy alone. The treatment effect size is gonna be a lot lower. You're gonna need larger sample sizes to actually demonstrate a benefit to neuroprotection and some of the other things, along with very good adaptive designs.
Raul, thank you so much. Absolutely. I have a feeling we have slides for probably give a full breakdown of each one of those slides. I guess I want to understand the whole question. It seems to me that there are certain things we might not ever be able to capture in a trial that you don't necessarily have that overlap. So, for example, you showed us, distal occlusion, bad outcome, even if it's a small volume, and do we treat those or not treat those, this match. More generally, specifically in that kind of thing, how do you make a decision on an individual patient, but more generally, to what degree do you kind of go off label and decide to enroll someone in a trial because you don't have equipoise and you think you have a better intuitive sense of what this patient needs?
Great question. First of all, my kids are here. This is Dr. Mike Ladd. This is actually, I wrote my very first abstract in neurointervention and stroke image with Dr. Ladd, so I'll be forever grateful for the time he spent with me. In relation to your question, I think that's where precision medicine comes, and it's why it's so key, right? Clinical trials give us populational data, right? It can't possibly give us the granularity of the patients that you are treating. So you have to incorporate common sense, experience, share decision-making with your colleagues and the family, and adapt the clinical trial knowledge to reality. But in general, what we have had in our field, and I had slides about that, is a lot of nihilism. If you compare us with, okay, do you ever see a cardiologist not treating a patient because has a big STEMI, the prognosis is too bad? Mortality of cardiogenic shock, it's 40%. Do you ever see an emergency room physician or intensivist not treating someone with septic shock because the Apache score is too high? Well, antibiotics are very expensive, vasopressors, ICU stays, very expensive. It doesn't happen. Trauma, the same thing. Oncology, right? You talk so much about cost. They put millions and millions of dollars to give people some more months of life sometimes. But life is very precious. So I think we have held us as too high of expectations, right? I think you need also to give the benefit of the doubt. This is a very powerful treatment. It's almost like antibiotics infection. So you have to have a very good reason not to treat someone. But I think the answer for your question is precision medicine. Absolutely.
Great presentation. Thank you for doing this. I would like to comment on the use of Acute in stroke treatment. It's very widely used. First of all, the numbers that we get, people just look at the number from the spot. Number two, we look at where it is predicting the core to be. The dice score between that and the DWI tends to be very poor. So not only is the number wrong sometimes, the overlap in the actual impact is way up. So given that, and given the performance of all the large trials, do you think we should still continue to use?
So I'll tell you, I think we're shifting the paradigm, maybe in big part because I trained here and I saw Mike Lev, Ben Schaefer, Gil Gonzalez, perfusion, diffusion. I think there is a lot of value there, but there is a time problem. I think specifically the new paradigm will be in the early window. If you can treat cores like aspects, even 0 to 2 or 3 within the first 7 hours, let's say, we don't need to know what the core is, right? So you should just take patients straight to the angio suite and bypass the CT scan and MRI scan. But if you're going to do a CT and a CTA, I do a CTP as well. Why? First, it helps me finding digital occlusions, which I believe we need the trials, I'm doing a trial, but I believe you should at least be studying them, right, and trying to improve the outcome. So I think the best reason to do a CT perfusion is to find a digital occlusion, right? It's the best technique for that. As you know, it's harder on CT angiogram. Another scenario is a patient that had intravenous thrombolysis comes to us, now it's reperfused and has hyperemia. Those are patients that I'm nervous about. I may want to be more aggressive about blood pressure to prevent reperfusion injury, stroke mimics. So I think it gives us information. And the way I do it, I either get no imaging straight to the angio suite, but if they go to the CT table, now these scanners like a G Revolution, you know better than I do, right? They can, it's 1 second to do a non-contrast CTA, CTP very quickly, right? So I think the problem is really the detour to bring the patient to the CT scanner rather than acquiring things. But you should never use it to exclude people. That is the key message. Don't use it to exclude people, but you can use it to include people, like the digital occlusions.
Will, so thank you. Since you have so much to get to prepare, are you about 4 times a year to teach?
If I come, I can finish my slides if I do that.
No, I think we have a soul of seniors, which is you can inspire and teach things that are very good to acquire next to your experience. We have people like this at FAHA. It would be awesome to have you.
I'm the prodigal son. I'll come back here whenever I'm invited.
My second part is, so this patient is married now. I know that it's doing very nice. Towards precision medicine, are you banking fluids and clots and anything that's great from the vascular procedures in a systematic way? We can isolate genetics of endothelial cells, of platelets, of anything, inflammatory markers, cytokines, astrocytes, cell composition. Is this happening systemically without research?
We should talk. We actually are the first people to start collecting clots here at MGH. You may remember that. We did scanning electron microscopy. Then I moved to Atlanta, never published the paper. I have a few of those projects I never complete, but it is a very hot topic now. We trying to start a biobank. Things have been a bit distracting from all the moves and then the new roles in administration, but there are colleagues, there is a big group very interested in clot science. We're very involved with that. We are actually about to publish the first large registry that did a lot of this clot science called the Excellent Registry. In terms of genetics, it would be wonderful to collaborate. We definitely should talk. It would be great for us to know how to preserve the blood and work with people like you that have the resources and knowledge to help us advance in the field. It'll be a pleasure.
First of all, thanks for the inspiration. Finally meeting you about the city, father and daughter, for bringing that as well. Talk briefly about the mismatch of supply and demand of vascular experts and how to keep training folks that know the techniques with all the new data specifically to the circulation.
So this is one of the big problems we have. There is a supply demand issue, and a lot of this control has to do with the fact that when one does neurointervention, you want to do everything, including brain aneurysms and AVMs and fistulas, and those diseases, if anything, they are decreasing in terms of what you can offer in terms of procedure. The incidence of subarachnoid hemorrhage is decreasing. I think we need to rethink about this pathway. I have been overall against the idea of training a neurologist to just do the ischemic disease. I'm rethinking that. I actually just hired a colleague to help me with some of my ischemic disease burden because I want to do my research and I have to take care of the center. And I think that is actually a model that you need to do. So I think you're right. Very much like cardiology branched out, right? Interventional cardiology went into, the typical coronary intervention, but now you have structural heart disease, valve disease, right? You have EP. I think we're gonna have the same thing with neurointervention. Maybe this BCI is just the birth of functional neuroendovascular therapy, right? And then maybe you're gonna have people more focused on ischemic disease, other people more focused on hemorrhagic disease, because I very worry when that old patient with the aspects of 3 comes 3 in the morning, what is gonna happen to that patient? But it looks like, based on the data, right, that we should offer treatment to those patients, and the guidelines are likely going to reflect that. And if you don't treat them, we are probably liable for not treating the patient. So we're gonna need to really rethink about our workforce. So, great consideration.
Thank you so much. With the next program, I want to thank his family because they are the ones who supported Raul and allowed him to do all the work here and to inspire the whole world. Thank you for being here today. Congratulations. Raul.
Thank you. Thank you.
Extraordinary. Amazing work. It's great style also.
I have the best.
How long are you going to do? I believe this in a year. You like this work?
I do. I like UPMC. I like the city. I don't like the West. But spring, summer,